what you're in for.
Family in prison too?
I would assume so. Well, I
Oh
would
no!
think
If
that.
you're a woman, they'll put you in like.
They'll take your baby.
No, you get to keep it for like 6 months. They'll put you in like a certain,
A special unit.
like a special jail cell
The
that has
maternal-
a crib.
It's like a
And-
maternal ward.
Yeah, that's
Yeah.
like and it has a crib, and then as the baby gets older, you get like less time with it, and then once it's like 6 or like 8 months or something like that, they take it away.
Jordan's speaking.
It's like a team.
And it's the adopted center.
They're just chilling in there.
They have those reality shows
I
about the
obviously
women
know
that are
this 'cause I'm
pregnant
one
in
person.
prison. It's very interesting.
It is. You know, human nature is very fascinating.
Yeah.
I could gather, by the way, just by the expression on your face, that you were not a fan of Scott Peterson.
No,
I think
not
that
quite.
Is anyone a fan
I
of
know.
Scott?
It takes a special person to kill their own child,
Right.
even if it's unborn.
A special in a bad way, you're saying.
Yeah.
Yeah.
All right. Now, these old spirometers use displacement of water, okay, to depict a graph like this. The graph was oftentimes printed out on a barrel in reverse. But in any event, I'm going to kind of fix this. Let's say this is a normal spirometry reading, pulmonary function test. Okay. Now, if you have the patient blow out, like I talked about, as forcibly as possible, okay, then, and you measure the vital capacity, that's called a forced vital capacity, FVC. Okay, where you coach the patient, you say, blow it as fast as you can, go, 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 okay? So let's suppose we're looking at forced vital capacity here. Okay, and we're having the patient blow out as quickly as they can. Okay, like this. And let's suppose that this is a normal tracing. Well, someone who has obstructive lung disease, when they're going to take that breath in, like this, okay, the slope is not going to be as steep. It's going to take them a longer time to exhale that vital capacity. So, one way to determine the severity of obstruction in a patient who's got obstructive airway disease is to measure what's called the FEV1, which stands for the forced expiratory volume in 1 second. How much they can blow out in 1 second. And you start at peak inspiration here. And on the x-axis, you measure out 1 second. Might be to here. So that this volume here that is expired in the first second is the FEV1. Okay. In a person who's got airway obstruction, that FEV1 is going to be a lot lower than it would be in a person who's got normal airways. That makes sense to everyone? Now, there are a lot of reasons someone might have airway obstruction. One we talked about before, asthma. You know, another term, but there's lots of terms we use for asthma. Like people call it twitchy airways disease, or people refer to it as reversible airway obstruction. The reason they call it reversible airway obstruction is because if someone exhibits airway obstruction like this on a baseline pulmonary function test, and it's from asthma, you can give them a bronchodilator, like albuterol, and have them repeat the pulmonary function test post-bronchodilator. And then if the bronchodilator opens up their airways, they're going to go from this green line to the purple line. You see significant improvement post-bronchodilators. Yeah.
So when the doctor asks you to do like a peak flow test where you put the tube in
Right.
there,
That's it. That's kind of a mini
A minute?
pulmonary function test.
Okay. I was just making
It's a
sure.
four-man's effort, right.
Related or not.
That's more or less for you to monitor your own pulmonary status at home, because you can carry a full
Right, yeah.
flow meter at home. Okay?
So wait,
But it measures the same thing, airway obstruction.
Right.
but I thought you said they don't give the pulmonary function test to people in distress. So like you wouldn't actually give it to someone with asthma, but
You could,
theoretically.
if they were in respiratory distress, okay, it would be hard to do it because they would have a hard time managing this.
So theoretically, that's what would happen, but you
But-
wouldn't actually give them
But
the.
typically what happens in many patients who have asthma, significant asthma, is they have some low level of bronchospasm all the time and just have intermittent exacerbations. And so if you would perform a PFT, it would depict some level of obstruction,
Okay.
okay? But yeah, if they came in struggling to breathe, you wouldn't be able to get them to cooperate, okay? Because most of the time they'd be very anxious, they'd be very, people who are hypoxic just can't do anything. They have that look in their eyes. But once they stabilize a little bit, then you do it. Okay. So this type of pattern would be called an obstructive pattern. Now, let's suppose, so many times you'll see a physician will order PFTs with and without bronchodilators, which means that you're going to do a set of PFTs without the bronchodilators, and then you're going to repeat it with to see if there's reversibility consistent with asthma. There are other types of pulmonary conditions associated with obstruction which are much less reversible. For example, someone's got COPD, chronic obstructive pulmonary disease, from smoking. Okay? They're going to have airway obstruction, but when you give them bronchodilators, there may be minimal improvement, but not near to the extent that you would see with asthma. Okay. But it would still show you, at least on the initial tracing, an obstructive pattern. Okay. Now, normally, if you take the ratio of FEV1 over FVC, that ratio is typically greater than 80%. In someone who's got significant obstruction, it's less. And the more severe the obstruction, the lower that ratio. Okay. Now, let's suppose instead we have a patient who's got, instead of having asthma, you have a patient who's got, let's say, silicosis, where they have problems with compliance. They have difficulty expanding the lungs. Instead of being called an obstructive lung disease, silicosis would be called a restrictive lung disease. In a person with silicosis, all of the volumes tend to be a little bit lower. Okay, so the tidal volume, instead of being 600, it might be 250. The vital capacity, instead of being 4 liters, it might be 2 liters. Okay? So, restrictive lung disease is characterized by decreased lung volumes and decreased capacities. Now, it's true, because of the lower volume and capacity, if you did an FEV1, the FEV1 itself, that number would be low simply because vital capacity is low. But if you do the ratio of FEV1 over FVC, it's normal. It's not an obstructive pattern. So pulmonary function tests can help determine if in fact somebody's shortness of breath is respiratory in origin, and it can help differentiate patterns. For instance, a restrictive pattern from an obstructive pattern. Does it always provide a precise diagnosis? No. The tests have to be interpreted by a physician or a PA. Okay. By the way, I'm impressed with just the number of people applying to PA school now. It's going up and up and up. Have you heard about that? they're going to have to start either opening more slots or opening more stools. We had a student last semester. Were you there when Jackie Wynn came?
No, I couldn't. I had a dinner to go to that night.
I talked to her because she started working at Oshner as a PA, and she's working in Oshner's LTAC unit where you have patients with vents and all these things. And she absolutely loves it. She absolutely loves it. She's got a team of nurses that work under her, okay? And of course, she's there, she's stationed in that unit. Okay, so she's responsible for all the patients, even though each patient has their own specific doctor. The problem in an LTAC unit is stuff comes up all day, okay, that has to be dealt with where you may have difficulty getting into contact with. So she's kind of the go-between between the nurses and the doctor. She can give orders to stabilize the patient while you're trying to contact the primary care physician. But she absolutely loves it. She absolutely loves it. Okay. Let's look again at the alveolus here. Okay. We talked about two types of cells. This is the type 1 alveolar cell here, squamous cell. And it forms part of the lining of the alveolus, across which gases are exchanged. And then this is a type 2 cell. This is the type of cell that produces surfactant. And then we see a dust cell here. Okay. Outside of the alveolus, we have a pulmonary capillary. In fact, you have lots of pulmonary capillaries that surround alveoli. What they're demonstrating here is the respiratory membrane across which gases move. We said the respiratory membrane is made up of the endothelium, the pulmonary capillary, the type 1 alveolar epithelium right here, and in white here, that little fused basement membrane between the two. Those three components make up the respiratory membrane. They kind of give a magnified view here. And so you kind of get the feeling that when we carry out external respiration, CO2 is crossing in one direction, oxygen is crossing in the other. They have to cross that respiratory membrane for gas exchange to occur. Now, the way we quantitate the amount of gas within the blood is by using its partial pressure. Okay. So, for instance, we can measure partial pressure of oxygen and CO2 within the alveolus within air. We can also measure its partial pressure within a fluid, like blood. Notice that the blood that's being carried by the pulmonary arteries is unoxygenated. When we say it's unoxygenated or deoxygenated, we don't mean that it doesn't have any oxygen, but we simply mean that the hemoglobin is not fully saturated. That, normally each hemoglobin molecule can carry 4 molecules of oxygen. So in unoxygenated blood or deoxygenated hemoglobin, not all 4 globin chains are carrying oxygen. So they're not fully saturated. So as a result, the PO2 of the blood being carried by the pulmonary artery is relatively low. It's only 40 millimeters of mercury compared to the PO2 within the alveolar air, which is 100. On the other hand, the CO2, okay, because this air is returning from tissues which are active metabolically, the CO2 is higher than the PCO2 within the alveolus, 46 compared to 40. Now, let me say this, is both oxygen and CO2 are lipophilic. There's no real separation of charge across the molecule, which means that they cross cell membranes very rapidly. Lipophilic. You all know what I mean when I say lipophilic? Or I could say
Soluble.
that they're soluble in lipids because they don't have a charge. Whereas if oxygen or CO2 was a polar molecule, it would dissolve readily in water, but not so much in lipids. The fact that these molecules are nonpolar means that they're lipophilic. They can cross membranes quickly. So as this blood from the pulmonary artery enters into the pulmonary capillaries, oxygen rapidly enters the blood as a result of this gradient, this pressure gradient. PO2 in the alveolus being 100, only 40 in the pulmonary capillary blood. Okay? In fact, it keeps moving over until an equilibrium is achieved, and the blood that's leaving in the pulmonary vein has now a PO2 of 100 milligrams mercury. With CO2, the movement of CO2 is in the opposite direction because the gradient is in the opposite direction. PCO2 is higher within the pulmonary capillary than it is within the alveolus. So CO2 is going to keep crossing over until an equilibrium is achieved such that the PCO2 in the pulmonary venous blood is 40. Now, so PO2 100, PCO2 of 40 in the pulmonary venous blood. These would be the same or nearly the same measurements as you would obtain from a systemic artery, like the radial artery. Why? Because this pulmonary venous blood is returning to the left side of the heart, and the left ventricle is going to pump it into the aorta and its branches. So when you perform arterial blood gases and measure the gas concentration of blood within the arteries like this, it's going to be very similar to these concentrations, these partial pressures present within the pulmonary vein. Okay? And this just shows you the change in partial pressure as the blood passes through the pulmonary capillaries. This is the PO2, suddenly it climbs. PCO2 falls. If we look at the hemoglobin molecules here that are being carried within the red blood cells of the pulmonary artery, each of these hemoglobin molecules is only carrying 3 oxygen molecules. So we would say that in this case, the hemoglobin is 75% saturated. So we can call it deoxyhemoglobin. It's not fully saturated. However, as that blood passes along the pulmonary capillaries, it picks up oxygen. So the blood leaving is now fully saturated, 100% saturated, because each hemoglobin molecule is carrying 4 molecules of oxygen. Make sense? Mm-hmm. Okay. Now, how is oxygen carried?